very excited to have all of you joining us today and having the opportunity to meet with Dr. Steineck, who is the researcher who we're supporting this year through the Advancing Cancer Research Council. And because of the fact that this group has not met Dr. Steineck, I actually wanted to start today by having some introductions of the group so that she can get to know us a little bit and who's joining this call overall. So we're hoping that we can start with the introductions from the group. It would be great for folks to provide their name, their location, so perhaps where you live. I know it's possible someone may be away from home. And if it makes sense, how long you've been associated with the ACRC through ACS. So because I know the Ireleys, if you wouldn't mind going first, I'm going to call on you if you're okay with that.
Sure, if you can see and hear us.
We can.
Great. So Joyce Irely and Mike Irely, we live in White Bear Lake, Minnesota. We've been, I guess, on the council since it started. Was that 3 years ago?
3 or 4 years.
And have enjoyed learning about and being part of the research projects up till now, and looking forward to hearing about Dr. Steineck's project.
Yeah, fantastic. Thank you. Can I turn to you, Gary?
Sure. My name is Gary Streit. I'm a lawyer in Cedar Rapids, Iowa. I've been volunteering for the American Cancer Society since 1977. Spent some time in the national board, was the national board chair 2003 and 2004. Continue to be real involved with ACS, locally, statewide. ACS can participate in the relay every year. Managed to raise a little bit of money doing that, and so really looking forward to hearing what you have to say, Dr. Steineck. I'm like the Ireleys. I think I've been on board since we started this program.
Fantastic. Thank you, Gary, for sharing all of that. Kelly, can I turn to you? If you're able to.
Hi.
Great, thank you.
It's Kelly Wap. Normally my husband is here for this as well, but he's at a conference in Colorado Springs. We currently live in Wichita, Kansas, but I'm a born and bred Husker. So yes, I appreciated that game a lot. April might remember how long I've been doing this. I don't remember. At least a couple of years, I think 3. I'm not positive on that. But yes, very educational, enjoying everything about it.
Great. Thank you for sharing. And just for my colleagues who are on the call as well, just a quick introduction. I know we may have done this in the past, but it never hurts. April, I'm going to turn to you since Kelly just referred to you, if you don't mind providing a quick introduction as well.
Yeah, I'm April Zubik. I'm in St. Louis, Missouri. I serve Missouri and Kansas, and I have donors who may jump in the middle, but I'll let you know the Greenwoods are also part of the council this year. It's their first year, and they are in the suburbs here of St. Louis, out in St. Charles County.
Fantastic. How about you, David?
Hello, everybody. David Yakel. I'm a director of philanthropy for the American Cancer Society. I sit in Omaha, Nebraska, and I work with donors in Nebraska, Iowa, South Dakota, North Dakota, Wyoming, and Montana. So I think we have Iowa and Montana represented this year on the Research Council. So thank you, everybody.
I think it's fantastic. David, I can never remember his 6 states, right? There's just like, I envy the fact that you can even just sort of get everything out very quickly, just because that's a whole group of states. Jade, do you want to say hello as well?
Yes. Hi, everybody. My name is Jade. You may have seen my name on some emails, including 30 minutes ago for this reminder. I am the coordinator for the North Region and this Advancing Cancer Research Council. So great to see you all here today.
Thanks, Jade. And I'll just say with my introduction, I sit in Madison, Wisconsin. I work with donors both in Wisconsin and in Minnesota. And what's kind of exciting about our opportunity to meet with Dr. Steineck today is that she lives in the Milwaukee area. And so I was able to meet her in person. Gosh, what was that? Last month, I think it was. So it was really nice to have the opportunity to just sit down with her in preparation for this conversation today. It's nice to, have more of a conversation with someone as you're getting to know them and a little more about the work that they're doing and the work that is supported, through the American Cancer Society and all of your support. So thank you. Couple of housekeeping items here before I turn it over to Dr. Steineck. Hopefully asking everyone, actually everyone's already done this, to mute themselves so that, she has sort of the floor to have the conversation today. And we're going to kind of go in a kind of a multiple steps. So we're going to start with a bit of presentation from Dr. Steineck, and then I'm going to open up some conversation with some questions that I have. But throughout, if there are questions that you have, feel free to put them in the chat, or, we can certainly insert those into the conversation. My understanding from Dr. Steineck is she's fairly open to just keeping this conversational. So while I know you have slides prepared, we're in a medium-sized group, so we're just open to having that dialogue. If something is curious to you, let us know. We're happy to have that part of the conversation. When we started this process with Dr. Hurst talking about Dr. Steineck's work, we learned more about the project and the fact that this is sort of related to CAR T therapy, and the title is supportive care intervention for children during CAR T cell therapy is something that Dr. Steineck will talk about today. But I also wanted to give you a slight bio on sort of Dr. Steineck and her background. She grew up in the Twin Cities, so Irely is probably happy about that since they are also in the Twin Cities area. Attended the University of Minnesota. And you said you have an undergraduate degree in genetics, cell biology, and developmental biology, which sounds like more than one major. So that's amazing. You completed your graduate or your undergraduate or your medical education at the Medical College of Wisconsin, Milwaukee, and it's there that you developed your passion for pediatric oncology. After that, Dr. Steineck completed a pediatrics residency at Stanford University and a pediatric hematology oncology fellowship in the University of Washington in Seattle. It sounds like it's when you were in Seattle that you developed a commitment to researching topics prioritized by patients and their families, seeking opportunities to incorporate the patient and family voice into clinical research to directly inform the improvement of clinical care. So sounds like you also wanted to move back to the Midwest after that time in Seattle, and you were excited to accept a faculty appointment at the Medical College of Wisconsin to continue to care for children with cancer and advance this part of your research career. So we're delighted to have you with us today, Dr. Steineck, and I will turn it over to you, and we're going to make sure those slides work, but we're excited to have you. So thank you.
Well, thank you so much, Kathleen, for that introduction. That was very kind. I'm sharing my slides. Can everybody see the slides? Not in presenter view.
I think you're good.
All right. So as Kathleen mentioned, please, this is meant to be informal. So if you have questions or you want to clarify something, don't feel like you're interrupting me. The slides are here as a prop to make sure that I share information that I'm hoping to share today. But again, my name is Angie Steineck. I am an assistant professor at the Medical College of Wisconsin, and today I'm going to be talking about amplifying the patient voice in pediatric oncology. So again, first of all, I'd like to start by saying thank you to the American Cancer Society and the Advancing Cancer Research Council, first for giving me the tremendous opportunity of doing the work, and also for inviting me to share with you this morning. I'm really, truly honored to be part of this team, so thank you for having me. Just a little bit more background about me. So as Kathleen mentioned, I was born and grew up in the Twin Cities in Woodbury, so just down the road from White Bear Lake. Like Kathleen mentioned, I attended the University of Minnesota with a basically glorified biology degree. It was all just one, not that fancy. And then I moved to Milwaukee to study medicine here at MCW about a little over 10 years ago. I went out west to finish my training, and then an opportunity came up back at MCW that I really couldn't pass up. And so I'm here, and I've been at the medical college for about 3 years now, and very happy to be back. So why did I choose medicine? I chose a career in medicine because I really wanted to help people, and more specifically, I wanted to help them feel better. And I felt the best way to accomplish this would be to be a physician. One, because I like a challenge, and two, because I felt like I could do meaningful work that way. Over time, this mission has really matured, but the core meaning of this mission has always been the same and has deepened. And it's just the vision of how to accomplish that goal has really evolved. So when I started medical school, I was very focused on the part of the job that was taking care of patients. I didn't grow up in a family where I hadn't had anybody in my family that was a doctor, certainly nobody that was a researcher. And so I didn't really know anything about research. I just wanted to be a doctor and take care of people. But over time, through the guidance of some really excellent mentors, I learned the important balance of being both a physician and a researcher. And so I really strongly feel that my medical training makes me a better researcher, and being a researcher makes me a better physician. And together, they have kind of this symbiotic relationship that they help me accomplish the goal of helping people all the better. I've also learned that it's very important to include patients and caregivers in this work. So to most effectively improve how we care for patients and improve the quality of the life of patients that I take care of, the opinions of parents and patients are necessary, not just important, but necessary. And if I don't know what the real problem is, I can't really fix it, right? So this is why I chose a research specialty in clinical research, and specifically in the realm of patient-centered outcomes research as my path forward to help people. So as I think everyone on this call is very much aware, we are in a very exciting era of cancer treatment, right? The past 20 years has shepherded countless therapies that are specifically targeted to different types of cancer. These drugs are often more effective and generally come with fewer side effects. And we are all hopeful that we are going to continue to move in a smarter direction with more effective treatment in pursuit of an ultimate cure of cancer. One such paradigm-changing treatment that it sounds like folks are a little bit familiar with here is CAR T-cell therapy, or chimeric antigen receptor T-cell therapy. And for those who are maybe less familiar with this nature of therapy, it's a type of immune therapy where a patient's immune system cells are taken from their body and genetically programmed to specifically target the cancer cells that are growing in their body. And for children with acute lymphoblastic leukemia, or ALL, which is the most common type of cancer that we see in children, this has been incredibly successful, particularly when other types of treatments have failed, so specifically traditional chemotherapy or even bone marrow transplants. However, unlike a lot of targeted therapies, CAR T-cell therapy has the potential to come with some really significant life-threatening side effects. And one of the most, I think, significant pitfalls of clinical trials is that we don't do a very good job of collecting information to best understand the patient's experience. For example, there is a way of collecting standardized side effects data directly from a patient or a caregiver, and this is called patient-reported outcomes, but this is not always done at the same time that we are collecting data about how effective a drug is. And so therefore, it's really difficult to understand what's most bothersome or what is most significant as far as barriers to receiving the therapy for patients themselves, or to how to best fix these problems. And that was the case with children undergoing CAR T-cell therapy. None of the clinical trials that have been done really collected this patient-reported outcome data. So early after I completed my training in pediatric oncology, I set out to learn more about what it was like to be a pediatric patient to go through CAR T-cell therapy and try to find ways to make it better. And so I did this by having both patients and their parents fill out surveys at multiple time points throughout the year after treatment. And then on top of that, a handful of the families participated in an interview so that I could specifically ask more questions about their experience. And so a lot of that was focused on the early therapy part of things, and also looking at things like what kinds of symptoms they experienced during their treatment, how they got to the point of making a decision about CAR T-cell therapy. And so what I learned is that families really unanimously felt that it was a clear decision, and that all but one family would make the same choice again, even for the families where CAR T-cell therapy did not produce a remission. So we had just one of the 20 families that I interviewed would make the same choice again. I also heard over and over again that families really didn't feel that the symptoms were significant, particularly in comparison to the other treatments that they had in the past. So whether that be intensive chemotherapies, bone marrow transplants, things like that. But on the flip side, families in fact wanted some symptoms to feel that the treatment was working. And so there was this different way of thinking about things than I had gone into it with my hypothesis. So being another thing that I've learned as a scientist is science is humbling, medicine is humbling. And so you learn a lot of things along the way. And then finally, I learned that families really found uncertainty to be a really great challenge during the entire process. So this parent of a 13-year-old girl said, I think if I would have known more about it and been more prepared of those kinds of things happening, maybe it wouldn't have been such a scary thing to go through. And so really coming back to this thought that coping with uncertainty can be a great challenge for families in ways where they feel sufficiently prepared for the side effects, unexpected events, and not knowing what the future may hold can be a really stressful experience. So I think this is something that we as humans can all relate to, right? Uncertainty, it feels uncomfortable and can be distressing, particularly when you are trying to navigate big life challenges like managing a cancer diagnosis, particularly when it's not responding to treatment, and particularly when it's your child. So life, I think we all can and recognize, is filled with unpreventable uncertainty. And for that, we can bolster our coping skills. I think medicine also comes with a certain degree of preventable uncertainty. So we as clinicians can do a better job of learning how to use clearer communication, for instance, to better address the concerns and fears of the families that we treat so that they can better understand what to expect. In children with cancer, we can use this model to manage both the distress of the child and the parent. And my hope and hypothesis is that in doing so, I can ultimately improve both the patient's and the parent's quality of life and make the process maybe a little bit easier. So that brings me to my ACS project. So for this, I have an outline of an intervention, a supportive care intervention, an educational program, if we're looking for different words, to help make the process of going through CAR T-cell therapy easier for families by trying to mitigate some of that uncertainty. And so I've got this rough draft of an outline with some slides that I'm bringing to families. And I'm interviewing patients, caregivers, and clinicians about this intervention and their priorities for what they want out of it. And I'm asking them to be really critical and give me all of the feedback to make it better and find all of the potential problems so that I can come up with the best product possible. And when I finish up with that, so I'm going to interview about 45 people, and I'm through a number of those interviews already. I'm going to take the end product and do a trial run of it, a dress rehearsal, if you will, and just make sure that it's in fact feasible. Can I actually do this? Is it acceptable? Do families find that this is an okay thing to be doing at the same time that they're going through CAR T-cell therapy? And is it meaningful? Does it actually start to maybe give us some signal about helping families? My bigger picture 10-year plan is once I come up with my final product, I'm going to more widely disseminate it. So I have a group of a few hospitals, children's hospitals, that I'm doing my dress rehearsal at. So here in Milwaukee, but also I'm partnering with folks at St. Jude and then out at Seattle, where I came from, working with some good friends who are willing to help me out. But after that, there are lots of institutions that offer CAR T-cell therapy and try to do this at a bigger scale to really answer the question of, does this actually make a difference? I'd like to think so, but I have to do this in a rigorous scientific way to actually answer that question. And if I find the answer to that is yes, then I would love to find ways to make this kind of thing available to all patients in pediatric oncology, or even more broadly, for instance, with the FDA approval of gene therapy in sickle cell and thalassemia. I think a lot of those principles of what families experience with CAR T-cell therapy can be translated very easily to those cases. So I'd love to be able to do that. That's my master plan for my career. So I have a lot of people to thank. It really takes a village, particularly my funders, so American Cancer Society and the Advancing Cancer Research Council. The MAC Fund is my home institution's support. So they have been profoundly invested in growing me as an investigator, which has been tremendous. I have an enormous study team, and I could not do this work without them. It really, really takes teamwork. And so I have listed some of my collaborators at different institutions, my clinical trial team here, and then as well as patients and their families, particularly Patrick McSweeney, who is a patient advocate who I have been working with for the past couple of years and sits on my committee to make sure that I'm staying true to my word and making sure that I'm on the right track. So he kind of acts as my North Star. I run all of my papers and my ideas by him, which he's been incredible. And then I have a whole panel of tremendous mentors. Jennifer Knight is my primary mentor here at MCW, but I have people from across the country, from the NIH to St. Jude to Seattle, who have all been tremendously instrumental to my growth as an investigator. So with that, again, thank you all for having me, and I'm going to stop sharing my screen.
And I, when Dr. Steineck and I connected, what I said is I'm happy to sort of ask some questions to help open our conversation about her work. I think she's given us a really nice perspective on it, but I imagine that there are questions from the group as well. So I have some things that I've already kind of started writing, and in fact I wrote some down as you were talking as well, things we haven't talked about. But before I do that, are there any initial questions from the group that for Dr. Steineck?
So I was curious, what is the age range of the children that you're dealing with then, Dr. Steineck?
Yeah, as a pediatric oncologist, I take care of people of many ages. So from birth until really 30, I would say. For ALL in particular, it's something that we see a lot in children. And so even those younger adults in the early 20s will get sent to us to take care of. And so we take care of patients of all ages. The research project that I'm working on, I'm trying to focus more narrowly. And part of that is because when toddlers and young children can't really provide me with really critical feedback on what I'm doing, just because of developmental considerations, right? But I think that is something that's really important to call out. So I'll focus mostly on teenagers just because they're best able to participate in the work. But I think including at some point, particularly parents of young children, is going to be necessary to make sure that we are being equitable in our access to resources.
Thanks, Gary. Anyone else before I ask some other questions?
So, hi, this is Joyce Ierly. I think I heard you say you're working with multiple centers. So I assume these are pediatric oncology centers around the country, or are you focusing on a small group of those centers at this point, or how many kind of institutions will be involved in your study?
Yeah, right now it'll just be 3 sites. So I'm working with St. Jude and then Seattle Children's Hospital. Seattle Children's Hospital, just because that's where I grew up, so to speak, with my training, and I still have a lot of heavily invested friends there that are willing to help me out. And then St. Jude, I have also worked with for a number of years on my earlier research, and have a collaborator and I would say really mentor who works out of St. Jude as well, who's highly committed to the work. And it also just happens to be that St. Jude and Seattle are also both really big CAR T-cell sites. And so it helps me recruit patients a little bit more nimbly than being just at one center.
Great, thank you.
I guess I'll follow up on some of those questions and ask, you alluded to some side effects that come when these young people are going through CAR T-cell therapy. Can you share what those are, just to kind of give us a frame of reference of what these families and patients are experiencing?
Yeah, absolutely. So there are 2 really hallmark and unique types of side effects that happen specifically with CAR T-cell therapy that we don't see in other places. And one of those is this very impressive systemic, so whole body inflammatory process where they get really sick and can have very high fevers and low blood pressures and almost look like they have a really severe infection. And so some of these patients will end up going to the ICU so that they can have blood pressure support, and sometimes even having machines help breathe for them or have pump their heart blood, work in place of their heart. So kind of like bypass. So that's the first class of side effects. And so, as you could imagine, can be quite significant. The second class is this inflammation, but really specific to the brain. And that can cause swelling in the brain and seizures and coma and things like that, but can also affect, as we're learning more about this type of therapy, headaches or cognition, so ability to think or focus and do normal life tasks, memory, as they are getting further out from their infusion. And yes, some of those things, like I mentioned, coma, can be very significant and life-threatening, but some of them are subtler, right? Memory and other attention tasks can be really subtle. And if we aren't asking patients themselves how they're feeling and how they're able to go back to school or communicate with their families, we might miss something.
So that it feels significant what you've just explained about inflammation, the body or the brain. Those are, I mean, you alluded to these side effects being impactful, but that is obviously, especially if you're a parent and you're watching your child experience this, I can imagine being incredibly overwhelming to experience. I don't know if it was on the slide that you showed about the CAR T cell, like the therapies, but can you describe a little bit like if someone is going through that process, what does that look like? And when you talk about these side effects, do they come up at what point in the, typically, when do they come up in the treatment?
Yeah, absolutely. That's such a good question. So if folks are familiar with bone marrow transplants at all, oftentimes what happens is we take blood from the patient in this case, and so that looks kind of like you're donating blood. They hook you up to basically a type of dialysis machine that sorts out the specific immune cells. And then the cells get shipped to a manufacturing lab, and that takes about 6 weeks for the cells to be modified in a way where they can be programmed to target the leukemia cells. So in that 6 weeks, the patient is oftentimes getting more traditional chemotherapies, not really intensive chemotherapies, but a lower dose chemotherapy to try to keep the leukemia at a tolerable or manageable level. And then the actual process of the CAR T cell therapies, we give chemotherapy, a type of chemotherapy to rid the body of that specific type of cell. So getting rid of a patient's T cells, because these are T cells, so a specific type of immune cell. And after about 5 days of that chemotherapy, we give the patient their cells back, which looks like a blood transfusion. It doesn't look very exciting. Patients can have acute allergic reactions to that medication, but that's less common. I think the two symptom or side effects that I mentioned happen at pretty stereotypical times. So as early as 3 days to about 10 days after the infusion, we can see that really big inflammatory reaction. And then a little bit later, about 5 to 14 days after treatment, we can see the neurologic side effects of things. So really the big scary things can happen really in that first month after treatment.
And typically for a patient's interaction with a physician, are they, after they have that infusion of the cleans, I don't know how you refer to them, but those cells, are they monitored daily? Are they at home? Are they in the hospital? You know, like how is that, you know, how do you keep track of that to sort of watch that emerge if it happens to become an inflammatory situation?
Yeah, every hospital is a little bit different. And I will say that this particular type of treatment is only offered at certain centers in the country. So it's not at every hospital. It's certainly not at every children's hospital. So families are often having to move to these sites, whether it's Milwaukee or Seattle or Memphis for St. Jude, for a period of about 6 weeks afterwards. Whether or not they're watched in the hospital or out of the hospital is very dependent on the practice of the hospital. So here at MCW, we do that in the hospital. In Seattle, we didn't. So it's not standardized. But typically during that first couple of weeks, it's at least daily, if they're not in the hospital, check-ins with the patient. So they come to clinic every day. But I think that there's also lots of opportunities to use things like patient-reported outcomes, and pair that with, a fancy Fitbit to try to monitor for some of these early symptoms, to catch them and be able to, smartly manage things in a way.
And do you see like the work that you're doing now kind of building towards this intervention piece?
Yeah.
How do you see, like, do you have kind of an idea of when that might come into play? Maybe this is too early to ask this, but like how would that get integrated into that process that you just explained? Is that a reasonable question?
You mean my intervention, how that might be involved in the observation for side effects?
Yes.
I would love for that to happen. I think that it certainly has the potential to be able to do that. I think it would require a couple of tweaks to it. And I think the shorter answer is that it's going to be a little bit more complicated, but I see my piece as one piece of the pie. And then, for instance, I have a really good friend at Seattle who is working on biomarkers after CAR T-cell therapy. And so looking at the blood and looking to see if there are certain hormones and proteins or inflammatory markers in the blood after CAR T-cell therapy. And can we do something that includes both patient-reported outcomes and tracking blood to see if a patient is going to develop these side effects? Yeah, I think that would be really, really cool, and definitely something that I would like to do long-term, but we got baby steps.
And I know I was sort of like asking kind of a larger question, and it's not one we actually talked about. So
no, that's okay. That's okay. I think
just curious.
That's my pie in the sky. If I could do anything in the world without any resource restrictions, yes, absolutely. That's what I would, my master plan.
I
I'll
have a
just stop for a
question.
sec. Oh, go ahead, April.
Yeah, Dr. Steineck, I'm curious, at the end of this, when you have this education for the patients or the parents, who's the audience? Is it the patient or the parents? Do they get delivered the same content, or do you anticipate that you might need something different for different ages of children versus the parent and what they're experiencing?
Yeah, that's a really good question. So for this first iteration, I'm going to have the teenagers and their parents do it together. Because I think, and what I've learned so far is that there's a really strong relationship between a child's well-being and the parent's well-being, right? And it's bidirectional. So if a child is stressed out, it's going to make the parent more stressed out. And if a parent is stressed out, the child's going to be more stressed out. And so I think doing it together has a few objectives. One, they're getting the information at the same time, and then I can tackle both, their distress individually. But also it opens up the door of communication between the patient and the parent to talk about some of these things. And I think from my other work that I didn't talk about today, that isn't always a given. I mean, everybody here has interacted with teenagers, right? They can be hard to talk to. And so giving them some prompts and making them feel safe to have these discussions, even with their parents about some pretty significant, important things, I think is a great opportunity. And so that's kind of my hidden agenda. To answer the second part of your question, I think it will evolve a little bit when I try to incorporate younger kids, but I still think that giving parents information that is understandable at the level of a child is still helpful. And there are ways that you can do that where you're satisfying both needs, but making sure that you're including a younger child's developmental skills.
I'm going to just pause and just ask again if anyone else has questions before I keep moving forward for Dr. Steineck. Well, with that, I'll just mention a couple of things you and I talked about last week. You talked about your own medical education, and then you've made a choice to sort of have a balance. You're in clinic and you're also doing research. Can you talk about how you came to that balance, or what led you to making that decision to have that sort of duality in your work?
Yeah, absolutely. Well, as I mentioned earlier, that was certainly not my plan from the beginning. And I think you and I talked about how I had this really pivotal experience as a resident. I was doing a palliative care rotation, and I was sitting down with the ex-head of pediatrics at Stanford, who is very committed to palliative care and supportive care. And he said, you need both. You need something else, because this is hard work, and to do it all the time can be really hard. And so having something else that you can pivot your focus to almost as a distraction is really important. But also you learn important things from both. So you can take things from the clinic and apply it to your research. You can take your research and figure out what you're learning and apply that to the clinical world and change how you're practicing medicine, which is really cool. And so I've felt and learned, maybe the hard way, that it's been an important balance for me to be able to do both. In Seattle, I had a job where I did mostly research. So I spent 80% of my time doing research and just 20% doing clinical. And here in Milwaukee, I'm more of a 50-50 split. And I've felt like that is really the comfortable balance for me, where I can really effectively take from one and apply it to the other, and still do a good job with both.
Gary, go ahead.
So we have a volunteer at the University of Iowa. Her husband's the head men's basketball coach, and one of their sons went through a cancer episode, and he was like 13, 14 years old. So they've been really interested in, the psychosocial aspects of teenagers and cancer. Is that intersected at all with any of your work, Dr. Steineck?
Yes. So my mentor out in Seattle, Abby Rosenberg, really looked at resilience, particularly in adolescents who are undergoing cancer therapy. And I think probably common sense, your psychological well-being is very tied to your physical well-being, right? So we feel the effects of our psychological distress. And I think teenagers being at that really pivotal part in their life experience that in a very different way than really anybody else. And so that is something that I've spent a lot of time looking into and thinking about. And one of the other reasons why I'm focusing on teenagers with this work.
I know you just talked a little bit about some of the mentors that have been important to you, Dr. Steineck, and we chatted about this earlier I think it was in February, April, that we saw Dr. Weber, and he's well established, well into his career, talking about being a mentor now. And you're in a space where you've referenced some of the mentors that are helping guide you today as you're sort of newly launching that kind of space. And you've talked about, the 50-50 between clinician and research. Talk a little bit more about who in particular has influenced your path. You've kind of referenced some of these folks, but are there a couple people in particular, and just share a little bit about how they've influenced where you are today?
Yeah, absolutely. like I mentioned, Harvey Cohen out at Stanford was hugely impactful in forcing me to take those times to reflect and talk about the things that you don't necessarily talk about learning in medicine. Claire Twist was another one of the faculty out at Stanford who actually showed me that you can study quality of life. And so kind of set me on that path, or that it is even an important question. So I think giving the space to even ask the questions that you are ruminating in your mind is helpful. And then Abby, I mentioned, similarly, didn't look at me cross-eyed when I talked about what I was interested in and passionate about. So it's kind of like finding your people along the way. And then here, there's a whole bunch of people. And one of the big reasons why I came back, Rich Tower is one of the oncologists here who was my med school advisor way back when I was a student, and has been somebody I've stayed in touch with and is also a great mentor. I didn't include him on my page of acknowledgements. But then we have this incredible psychosocial team that is just really collaborative and an excellent resource, and they've also been pivotal. So too many people to name, Kathleen. That's the hard part.
But it's obviously, I mean, you have a community of people that are helping you as, you're launching. We heard from Dr. Weber. I think he's 30 plus years into his work, April. Is that fair to say? Things will shift in time, and then you'll be one of the folks that, people are talking about. So I think it's important. And it's great to know that you're in a community of folks that are helping you grow and understand what's best for your journey and your curiosities. So I think that's exciting. Can you talk a little bit about your lab? So my understanding with this group in the past is that, like, April, I know one of the researchers, I don't know, was it Dr. Hahn that you did the lab tour with? Is that okay?
Yeah.
So, this group has seen lab tours in the past, just to show, but your lab is a little different. It's more of a dry lab. So can you explain how that varies from maybe what folks are familiar with what Dr. Hahn did? That's probably like 3 years ago, April. Is that fair to say? A couple of years? So can you talk about sort of the differences in the styles of labs that people are part of or run?
Yeah, I think the biggest difference is the physical space. So most of my time I spend on my computer. So it's my office, which is not very exciting. I've got some bookshelves and a desk and a computer. And then it's really the people, I think. So unlike a lab where you have pipettes and mice or, whatever else you're doing your experiments on, I work with people, and that's one of the big reasons why I chose clinical research, is because that's my favorite part of my job. So I have my teammates, where I have my research coordinators that help me do the work and, do a lot of the paperwork, work with medical students, which is also really exciting to, start to be able to pay it forward. And then I get to hang out in the hospital and interview patients and parents and my colleagues and talk about things that are most important to them. And so it's less of a place and more of a environment, I guess, would be how I would explain my lab.
And because of that, I think this group, for our next kind of meeting of this group, we're looking at doing that in November, and perhaps Dr. Steineck bringing some of the team members, because it's not necessarily a lab where we can show you a video of this is what it looks like. It's more to talk about how does this process work, so that we can kind of understand what are those conversations with the patients and the families? Because I think there's more to explore in that space. So just know that for this group, we're going to look at November for our next call and sort of understanding a little bit more of the breadth of the work that Dr. Steineck does, just to kind of get a better read on what a dry lab is compared to pipettes and beakers all over the place. So I think it's neat to have that understanding of the variation of some of the research that we've supported as a group over the last number of years. It's all going to look different. So we appreciate that you're willing to kind of let us into some of that process and how it works. I know it's almost 7 minutes before the hour, so I just want to stop and say if anyone has any other questions for Dr. Steineck. Just want to make sure.
Maybe
I-
just a last one. We have
Yeah.
some amazing donors here and who will listen to the playback who are so interested in research. And like Kathleen is saying, the work that you're doing is so different than what we funded before. Just anything that you would like these donors to know about the impact of this grant on your work and what may or may not have happened without this grant?
Yeah. I think just to say that this work is not possible without everybody's help. So I am really indebted to everyone here for believing in me. I think this work can't be done, unfortunately, without money to support it. And so I think the ACS and other philanthropic organizations are really important because you guys get to choose the work that's most meaningful to you. And I feel really tremendously honored that I get to be part of that. And so I feel like I have a sense of duty to really continue having you guys be my North Star in guiding this work forward. So yes, absolutely, tremendously important.
Mike and Joyce, I see you came off mute. Did you have?
No, I just wanted to thank you for your sharing your research. It sounds really exciting, and we look to hear more.
Thank you. I'm excited to continue to share some updates as I get some work done.
We're very thankful for Dr. Steineck for taking the time to be with us today. And as I said, I think this is sort of a preview. We'll have continued conversation with her over the next few months because we're curious and always wanting to know what's happening and what's developing in your work. We know it takes time, but your perspective is one that we really value. So I just want to say thank you to Dr. Steineck for joining us today, and thanks to all the members of the ACRC for being part of this and for everything you do to support that work and research. It's incredibly important, as Dr. Steineck said, and may not exist without your help. So that's important. I was going to just say November, we'll get a date out there to have a second part of this conversation to learn more about Dr. Steineck and her work. I think Jade will probably be the person to help make that happen. And then one other quick invitation we wanted to provide. Jade, I think you have a slide for this. Well, that was very quick. The work that we do with the ACRC is very much centered on research, but we just wanted to let folks know about, there's a webinar coming up at the end of October that's going to talk a little bit more about the patient support space. This is, we will send this out, so you don't need to furiously write anything down, but I just was going to mention this is something happening through our Access to Care Solutions team. And they're the ones that maybe you've heard of this, oversee things like Road to Recovery and work in the lodging space. But yes, we're focused on research here, but always wanting this group to know about other opportunities available for you to get involved and to learn more about the work that's happening with ACS. So this is one part of that. And I think we also will do something in February of 2025. I don't think it's urgent right now to get that on your calendar, but just to share more about some of the research happening within ACS. I think we are very fortunate to have this access to Dr. Steineck over the next period of time, and really thankful for everyone for being involved. Unless there are any questions or anything I missed, my team, just to ask that question, did I miss anything? April, David, Jade, we're good? Just want to say thank you all for coming today. Certainly the folks that you're familiar with, that you work with, will reach out and get your impressions on how we can create something for November that's also valuable. So thanks everyone for your time, and take care. Have a great rest of your Monday. Bye, everyone.